then it must be a rheumatic valve disease. Otherwise, it may be a post-heart attack, or it may be because of infective endocarditis or dilated cardiomyopathy. So what are the structural changes? As I just said, it could be annular dilatation, it could be leaflet retraction from fibrosis and calcification, it could be caudal abnormalities and LV dysfunction. Now, what is the advantage of having valve repair? See, basically, you're born with your own valve. So it's best to keep your own valve within your own body. Therefore, you have the best ever valve remaining with you. You do not require any anticoagulation. So all the problems of the valve getting choked or bleeding in the brain is not there. And because the left ventricle is part of the entire mechanism, if you are maintaining the patient's native valve, then basically what it happens is it preserves the left ventricular function. And patients can go into contact sports and everything. So if it is a stenotic valve, then Dr. Ganguly and his team of cardiologists all over the world has taken the initiative away from us, and therefore they do the commissurotomies. But if it's a regurgitant valve, and it is because of annular dilatation, all you need to do is put in a ring. And if it's a leaflet prolapse, then if it is in the posterior mitral leaflet, what you can do is a quadrangular resection. I'll show you. And if it is in the anterior mitral leaflet, you can shorten the leaflets. And if it is a leaflet restriction, then what you do is a caudal split. Now this is Carpentier's classification, and as I said, that type 1, I'm repeating this again so that it hits your brain and you have some recall phenomenon after you leave this hall. Type 1 is annular dilatation, type 2 is because of elongated chordae, and type 3 because of shortened chordae and subvalvular crowding and leaflet restriction. Now, as I said in my previous slide, that this anterior annulus is fixed, but the posterior annulus is not fixed. It can dilate and it causes regurgitation. Failure to coaptation of leaflets. So how do you do, this is very important for even patients who are remotely associated with cardiology. I mean, even MD physicians and people who see patients every day, this is important for them. Please listen. The best way is that to understand when you will refer a case for a mitral valve regurgitation, because mitral valve regurgitation patients are rarely symptomatic. The day they become symptomatic, it is too late. So you have to pick up these cases pretty early in life. So the most important determinant is to assess the degree of MR, and that you have to do by ERO and the regurgitant volume. Otherwise, all echocardiographers will show you this is the degree of MR, this is the way the blood is coming back and stuff. So effective regurgitant orifice, ERO, please write it down on a piece of paper, that it is the most important outcome predictor of patients of MR being treated conservatively. And secondly, and it's an indicator as to when to proceed for asymptomatic patients with MR. So now as I come on show you this, is that, see, when the ERO is less than 20, MR degree is mild, and the 5-year death rate is 3%. So what will you advise your patient? You will advise your patient that you do 6-month serial echo, and you must do frequent serial echo. If the ERO is between 20 and 39, then the degree of MR is moderate. So you must do frequent serial echo and do an early repair. Don't wait. Just ask the surgeon, please do the repair of this regurgitant valve. If the ERO is more than 40, it is said to be severe, and the patients, 36 patients of these patients will die within 5 years. So you must do an early repair. So ERO is very important. So whenever you send your patients to Mission Hospital for an echocardiogram, you must say, I want the ERO. And the regurgitant volume, if it is more than 60 ml per beat, then it is important that you get the repair done, whether or not the patient is symptomatic or not. Now, what do you do with a posterior leaflet prolapse? So you've seen that, you know that there are 2 leaflets. So you do a triangular resection or a quadrangular resection. So this is what is called a quadrangular resection. This is the posterior mitral leaflet. You remove that quadrangle, and you suture it and then put in a ring. It's fantastic. It's a very good repair. Another is the commissuroplasty. The anterior mitral leaflet, if it regurgitates, then it is one of the most difficult situations. You have to reduce the height of the chordae and put artificial PTFE chordaes. What can transfer the chordaes from the posterior mitral leaflet to the anterior. And another thing which cardiologists are gradually taking away from us, but thank God that the results are not good, is the edge-to-edge mitral clip. Now this is how we shorten the elongated chordae. We cut a trench in the papillary muscle and put it downstairs. And these are the artificial chordae that we put to repair the mitral valve leaflets. And that is how we do a caudal repair, a caudal transfer. We take out chordae from the posterior mitral leaflet, put it in the anterior one. And this is the edge-to-edge Alfieri's technique, but we need to have 2 centimeters of valve area on the other side. This is how we put in the mitral valve ring. I'll show you a small video at the end. So this is another question. When do you refer a case for mitral valve surgery? The earlier thoughts were that when a patient is symptomatic, then only you send. But so always remember, as I said in my little earlier, that the patients with MR have delayed symptoms. And previously we used to give enough of Lasix, ACE inhibitors, digoxin, etc., and wait for the left ventricular to dilate till 55 millimeter and then replace the valve. That is not a good thing. These patients will not live for a long time. So present thoughts are that any symptomatic MR must be referred for surgery, and asymptomatic, MRs with ERO more than 40 millimeter or regurgitant volume more than 60 must be sent for repair. Patient will then have his own leaflets, his own chordae, his own papillary muscle, and live for a longer period of time. So this is our results in the last 36 months. We have had 62 patients with rheumatic mitral valve regurg. All of them were successfully repaired. We did 21 patients with post-MI mitral valve regurg. We had 3 deaths because of hemodynamic compromise. And there are many patients with mixed lesions in which there were mitral stenosis as well as mitral valve regurg. There were 346 of them. 74 of them could be successfully repaired. The others we had unfortunately had to replace. This is the commonest lesion that we have in our practice, is that this type 3P, when the posterior mitral leaflet becomes small. This is how we cut it out. I'll show you a small video also. And then we put in an autologous pericardial patch to enhance the posterior mitral leaflet. And this is how it looks. And then we put in a 32 size or whatever ring. This is called the C ring. And this is how I don't know how it changes the color from red to blue. But I think I was talking about red and hot. This is blue and cool. You enjoy it. And this is the beautiful, beautiful results. See, the heart is beating. This is the mitral valve ring. Fantastic repair. There is no regurgitation at all. See, that's the repair. And this, what we have done is put in a cardioplegia so that see, again, it is totally coming out the blood moment I put something inside. So this is fantastic. Now this lady is doing very well. This is one of the other children, 22-year-old girl whom we repaired valve successfully. And this is our team. We have a huge team. Again, we have all this girl is wearing red, color is coming in blue. So red and hot is not an art thing. We are blue and cool. So the surgical team, this is Nityanand, the anesthetist. He's from All India Institute of Medical Sciences and does fantastic TE, on-table TE. Previously, we used to call the cardiologists from the OPD or their cath lab, bhai aake karke jao, and they used to tell them, mere paas time nahi hai. So nowadays we don't call them. We do our own TEs. And this gentleman is responsible for teaching us, Dr. Bangubas, Dr. Srirup Chatterjee, that is Dr. Jaydeep Trivedi, Dr. Suraj Pradhan, and small little me, and rest of the team of anesthesiologists, critical care specialists, nurses, technicians, and so on. This is just part of the team. There are more as well. Thank you very much for whatever time you spend with us. Hope you have a great conference, and